Hello everyone, welcome to this week's EKG. We have a good case for you this week, starting with a 69-year-old female who tells you she has a history of high blood pressure, high cholesterol, diabetes, some chronic kidney disease, and today she's having really bad neck pain and just generally doesn't feel well, and so she's overall kind of weak and very tired. Get a set of vital signs and you see that our heart rate's 87. Blood pressure's a little high at 214/82. Oxygen levels look good. Blood sugar looks good. Respiratory rate's normal. But this crew was very astute here in recognizing that she had a lot of risk factors for coronary artery disease. And she is an elderly diabetic female, and sometimes this patient population can present a little atypically. So they recognized the risk factors: high blood pressure, high cholesterol, diabetes, elderly. I don't think she smoked, but they went ahead and got the 12 lead, and this is what they found. So I'll give you a second to take a look at it, see what you think, and then we'll go through it together. All right, so just like always, same way every time, we start with the rate. The computer is telling me that our rate is 85, and I'm gonna just see if I can confirm that with my eyes. So I find a QRS that lines up with a thick red line right here, and then I count down to the thick red lines: 300, 150, 100, 75, somewhere between 75 and 100. I agree with 85. That rate sounds reasonable to me. Next is the rhythm. We ask two questions here. Is it regular, and is it originating from the sinoatrial node? So in general, this looks like a pretty regular rhythm to me. I don't see any irregularities, short gaps, wide gaps between the QRSs. And then, are there P waves before every QRS? So I tend to either like to look in lead 2. Sometimes V1 is an easier place to see P waves as well. I see a P wave here before the QRS, and they pretty much march out. There's a little bit of artifact which makes it difficult here, but I think I can kind of hallucinate some P waves in there on our way throughout the precordium here. So we'll call this a regular sinus rhythm. All right, so next we're gonna go ahead and move on to evaluate our axis. This is where we look at leads 1 and leads AVF. If you remember, we use our thumbs. So left thumb is lead 1. The majority of our QRS vector is up there. That looks good. AVF is a little, I would call it maybe isoelectric, a little hard to tell. You may be able to argue it's a little bit downward, but for our purposes here, we'll call it mostly up. That'll give us 2 thumbs up. Normal axis here. So we move on and we look at our intervals. QRS and our QTC are going to be the ones that we're most concerned with here. QRS is normal and narrow if it's less than 120. QTC, we like to be less than 450. Remember, at 500, you're at risk for spontaneous arrhythmias. These both look really good here. No concerns. The focus of this week's 12 lead is going to be these ST segments. And so we do this the same way every time so we don't get deceived. I like to start with 2-3 AVF just because I read from left to right, looking for any ST segment elevations or T wave inversions. And these inferior leads look okay to me. I tend to move to 1 and AVL next, and this is where it starts to grab my attention because it is never normal to have an inverted T wave in AVL. These are your high lateral leads, and that's usually a signal to pay close attention to your inferior leads and get another one and watch for developing ST elevation in your inferior leads. But we're okay here for now. As we move more towards the septal and the anterior leads, what we see is more ST changes with T-wave inversions here in the septal leads, all the way V4, V5, V6, and I think I may see some very subtle beginnings of ST depressions there as well with T-wave inversions. Now this is very important because if you remember at the beginning, we talked about all the risk factors that this lady had for coronary artery disease. So these, although this isn't a STEMI, there's some very concerning T-wave changes on this one. And what we're focusing in on here is these T waves. Now, your biggest clue to ongoing cardiac ischemia is going to be ST segment depression. And there's different types of it. There's upsloping, where you look at the slope at the beginning of the T wave compared to the QRS. In general, upsloping is not as concerning as downsloping or horizontal, but I don't want you to take away that any sort of ST segment depression should catch your eye and should be concerning in the right clinical setting. But in general, upsloping is a little more benign than the downsloping or the horizontal. Now, very importantly here, any downsloping ST depression in greater than 2 leads is very concerning. If you see it sequentially in leads that are looking at the same area of the heart, that should catch your attention. And if it's greater than 1 millimeter in 2 contiguous leads, again, very concerning for ischemia, so pay close attention to your ST segments. And these ST segments can take a lot of different forms in the way that they can be depressed. So you can see different pictures of different ways that these ST segments can change here in an ischemic setting. If you do see greater than 2 millimeters of ST depression and greater than 3 leads, this is a really significant indicator of increased mortality. So just because there's not a STEMI doesn't mean there's not something going on, and you need to pay close attention to these ST segments. Another just point here to look at when you're trying to determine exactly how much depression you have, you want to look at your TP segment. So remember, your previous T wave will be over here leading to the P wave, and your TP segment is what you're going to use as your baseline to see if there's actually depression there and to measure your depression, okay? Other things that the T wave can show us, these T waves are very useful, is T wave inversion. So the ST segment may not be depressed, but in some forms of ischemia, your T waves can start to be inverted. And they can also take different shapes, so pay close attention to them. Inverted T waves just simply means there's a deflection is going downward. Peaked T waves we know signals hyperkalemia probably, but T waves can also flatten or have a biphasic appearance, and this can also indicate that there's some sort of ischemia going on. Now, it's very important when you do see T wave changes to put them in the context of your patient, because there's other things that can cause T wave inversions as well. So left bundle branch blocks, right bundle branch blocks, some types of hypertrophy can do this. So it's not always a signal that there's coronary artery disease, but it can be. So it's important to pay close attention to them. Really what's going to guide you here is your history. And so this lady was having exertional shortness of breath. She's very fatigued. She's an elderly diabetic female with a lot of risk factors, so we're very concerned about these ST depressions and T-wave inversions for her. Remember that one EKG begets another, so if you see something that catches your eye, just follow that serially. Get another one, see if things are changing or evolving, and then be sure to give aspirin if they have a concerning story, because that's the one thing we give in the pre-hospital setting that helps with mortality. Okay. And here's one more look at our 12 lead with our very concerning T-wave inversions, kind of diffusely with some developing ST segment depression over in the lateral leads here. And that is all for this week. Thank you for your attention, and we'll see you next week.